Oh, hey, Chris.
Hey Chuck, that's a little low energy from you over there. What's going
No, plenty of energy. I was going deep, deep.
on? How's your morning been? We're recording on a Saturday morning.
My morning's been pretty good. I had a long week, a lot going on, and I woke up. I get up early despite my best intentions, and got some work done. And then I was just sitting and reading and having a delightful morning. And then I got the text.
Okay, so what does a weekend of work look like for you? Like what kind of work are you knocking out on the weekends?
It's usually a combo. I try to make it a combo. It's not clinical. My thing is I don't like to leave any particular day without clinical work done. That means all dictations, all phone calls, all MRI reviews. So I'm pretty good about that. And then weekends are for admin mainly, department work, I guess I should say, but also research. I don't like it if it gets tilted too much toward administrative work and not enough research work. So it's usually a combo.
Okay.
What about you?
Well, so we just finished doing our annual cadaver brachial plexus lab and peripheral nerve lab. The folks at Axogen were kind enough to bring in a guest speaker. And since I think probably the last 5 years, we've actually taken this as an opportunity to bring in a torso specimen and in today's case, a whole body specimen, which we're incredibly grateful for because the opportunity to do dissection around the neck and fully around the shoulder without the shoulder being disarticulated is really helpful because those are all the nooks and crannies of the anatomy that are very tough to get at otherwise. For obvious reasons, it's very difficult to secure those specimens. So we had a great time in the lab this morning.
So you dissected obviously both sides, big plexus dissection. Wow, that's awesome. And it was you, I'm guessing Brogan and our three fellows.
Yeah. So one of our fellows couldn't make it, had a family emergency, but otherwise, yeah, we had a great time. And several of our residents came, and they were working on working on extremity specimens, and one of our hand therapists came. So it was just a fun time, and it was interesting. Shout out to Jamie Findice, who does a lot of our brachial plexus therapy, and she works with Athletico, and she took it on her. She took the initiative and came into the lab and we actually did a free functioning gracilis of sorts. David harvested the gracilis. I inset it in there. And then she's like, has a newer appreciation for the surgery, which was really cool that she came into the lab and hung out with us.
Cool on many levels. That first of all, labs like that are priceless. And I know you already said you appreciate it. I know our trainees did as well, and Jamie as well. And that's the second part, is having great therapy partners. We've said it over and over and over, is priceless, and yet another demonstration.
Yeah, and we've been rehabbing more nerve transfer patients together, and I showed her some of the nerve transfers that we were doing for radial nerve palsy, and I think just having her see the anatomy is super useful, and just fun all around. So yes, it was a wonderful lab, and I hear that you've been in the lab too recently.
I have, I don't do, big brachial plexus work, but I am intrigued by a new endoscopic carpal tunnel tool called the carpal clip that a friend of mine helped develop, and been wanting to try it. And I have to say, I walked away impressed. Did 5 cadavers. It was quick. It felt incredibly safe. Visualization was excellent. So next step will probably be to set up a few of these on patients. I give full disclosure in these situations to the patient, pros, cons, my experience, and probably do a couple more cadavers, right before, and give this thing a shot. It really is quite nice.
It's interesting you say that because I am also in the midst of trying a new type of carpal tunnel release technique, and it's using ultrasound guidance. And so I have done 2 labs now, have a third lab scheduled, and just trying to get more reps with the ultrasound and using that guidance. And it's interesting. I think next week we're going to have a discussion about, the What's New in Hand Surgery article, and it includes some discussion about endoscopic versus open and the pros and cons. But yes, of course, obviously making sure that we feel comfortable with the new techniques, disclosing it to patients, the pros, the cons, and then seeing where it goes from there. I don't know for sure if I'm going to use it. I obviously have to feel comfortable before I make that decision.
Yeah, absolutely. We have to be 100% comfortable, and there's an absolute requirement to be to be forthright with our patients about this process. So We should both report back in whatever it is, 3 months or something like that, and share what, if anything, has happened.
For sure. So what are we talking about today?
You know, I keep hearing whispers that we need more sports. I
Well,
keep hearing
especially
it.
after last week's congenital episode.
And I agree. We need
you
more
gotta
sports.
come back strong, get people going again.
So you know what? Despite a lockout, baseball is hopefully around the corner. Let's talk about some basic baseball injuries and concepts around them. What do you think?
Well, I think so, because I mean, St. Louis is a baseball and hockey town now. We're recording this the weekend of the Super Bowl, and I guarantee you there are very few people in St. Louis cheering for the Rams.
That is right. The whole playoffs, all I've been about is that the Rams not make the Super Bowl. So one thing's for sure, I'm cheering for Cincinnati this weekend.
Yeah.
No doubt. But I would add one thing to what you said. We are about to be a Major League Soccer city. We were supposed to start in March of 2022, but because of the pandemic, it got pushed back. But the organization is awesome. And it's been very enjoyable interacting and kind of watching them grow. And so I'm looking forward to that for sure.
Well, can we just for everybody else, we're recording this the weekend of the Super Bowl. So Chuck, do you have any predictions? Because this episode is going to drop after the Super Bowl. So what's the score going to be? How's the halftime show going to be?
What's a couple of remarkable things. One is just the gambling around, the legalized gambling around this is stunning. And as most of the listeners know, I don't personally have any experience. You can wager on anything. The length of the national anthem to, anything you can think of, the over under, the first touchdown, everything. I'll be honest, I don't follow the NFL as much as I follow college football or the NBA. But I hope and actually do believe Cincinnati's going to win by a touchdown.
Okay, well, Cincinnati. You lived there for a year, so I'll give you that. I would love it if Cincinnati won. I don't think it's going to happen. It's funny. I was writing what the AFC Championship. I was when they were playing the Chiefs. I was writing an email to the group, and I jokingly said, when you're done watching the Bengals come from behind victory, take a look at this. It actually came true.
Came true. I loved it.
So I think the Rams will pull it off, even though I truly do not want them to. So yeah, we'll see who is right. This episode will drop the weekend after.
You're probably planning a feast of some sort for this event, if I know you.
Oh yeah, there's gonna be all the things. For better or worse, I'll be preparing my waistline. So
Nice.
We'll see how it goes.
Nice.
So yeah, baseball. So tell me, what are the most common, what are the three most common hand injuries that occur with baseball? And do you have to distinguish, batting injuries versus pitching injuries or throwing, catching, that kind of thing?
Yeah, I think for this audience, and certainly we could dive deeper and we can even have a guest on, which might be fun. When we think about throwing injuries, it's predominantly pitchers. Obviously, shortstops and third baseman can put a lot of torque on their arms, but obviously we're talking about the repetition and the velocity of pitching. I vote, let's save that for another episode and have a guest on. That could be fun. What might intrigue you is how often I'm addressing, and maybe you are as well, but I work with our sports partners, and it's not uncommon that we work together on a medial elbow where the UCL is reconstructed and the nerve is transposed. The goal, of course, is not to need to transpose the nerve, but if the nerve is irritable or unstable, then it, in my mind, is the right thing to do. Do you have any thoughts on that?
Well, do you see mechanical irritation of the ulnar nerve in these athletes in the setting where they don't have medial ligamentous issues?
Yes, and that is especially in the adolescent population. And this is my theory, and you may have different thoughts on this, but my theory is that, we think about a third of the population has ulnar nerve instability. And we looked at that previously, and there's been some ultrasound studies on that as well, which are certainly more accurate than clinical exam studies. I believe what happens is, for whatever reason, the nerve gets irritable. And if it is irritable and it is unstable, I do not find that those resolve very often. And so especially an athlete who is hesitant to take time off to get it to calm down. So I think once it becomes stirred up, even if the UCL is stable, addressing that ulnar becomes a priority if the need is to get back to play.
How long and what kind of non-operative treatment will you give them? Is this kind of like going along lines of pitch counts, or is it night splinting, the normal stuff that we do?
If we're going to truly try to calm this down, it is an absolute no throw for 6 weeks. Nighttime splint, daytime motion, but no throwing, anti-inflammatories. That's my regimen. If they are making progress at the end of the 6 weeks, I will extend it for another 6 weeks and see what happens. Of course, there's a big difference between reconstructing the UCL, where you're looking at a year or more, and transposing the ulnar nerve, where honestly by 8 to 10 weeks you can be back throwing full force. So I don't want to be knife happy by any stretch, but also in a high level athlete, I don't want to just immobilize weight when the reality may not be so positive.
Do you see any role for nerve studies or ultrasound diagnostically in that particular population?
Absolutely not opposed to it. I don't believe it's always necessary or helpful. An unstable nerve, again, love to hear your more technical thoughts. An unstable nerve without hand-based symptoms, that is normal sensibility, normal strength, it's unlikely to test positive based on the basics of the EMG and nerve conduction sensitivity. So I don't rush to do a nerve study.
Yeah, I guess the way I would think about it is that if it's going to change what treatment I offer, then yes, I would get it. And I would want to know what your particular transposition, or maybe it's just a decompression, but what your particular treatment would be. Because for me, if I would probably still use my current algorithm of an unstable mechanically irritable nerve without any signs of denervation is going to get a subcutaneous transposition with a nice adipofascial fat pad flap kind of transposition, like the guys from Columbia described. If it's signs of denervation and anything more advanced on a nerve study, I probably am going submuscular, but I don't treat the throwing population as much. So how does that affect what you do?
First of all, I would like to say thank you, because I have been for many years an advocate. How did you do this? How did you turn this podcast into a nerve discussion?
You did. You did actually.
Not intentionally, and not, but we'll go down this garden path. I was an Eaton flap guy, so I raised the fascia from the flexor peroneal mass to prevent the nerve from subluxating posteriorly. Liked it, but never loved it, because what I think happens is the nerves scooches, and that's a nerve term that Chris likes to use a lot. The nerve scooches medially and rubs up against the medial epicondyle. And so I played with different techniques, but I've never loved it. I now use that fasciocutaneous flap as long as there is sufficient fasciocutaneous tissue, and love it. I think the recovery is faster. I'm more apt to get them moving without limitations faster, which speeds an athlete's recovery. I really don't do decompressions in this population. I just don't think it has a role with the forces, et cetera. And I don't like submuscular for, I guess, somewhat obvious reasons. I'd rather not cut the muscle and ask it to heal and achieve the same strength it had previously, even though it probably will. My preference is subcutaneous.
Yeah, I think the key with the subcutaneous, and again, we'll get off of the nerve stuff, but it is making that a very broad pillow, and making sure that you're not doing anything that's going to be small and tight. I think that's my main beef with some of the, subcutaneous transpositions that use a fascial sling, is that I've seen people do it and it ends up being a very thin band of tissue that looks a little bit like a transverse carpal ligament, to be honest with you, once you put it in. And clearly it works in many situations, but I've also had to revise enough where I appreciate having a very broad area, because obviously a broader area is going to distribute the forces more evenly, the tension more evenly across the nerve that's been transposed.
Yeah, that is well said. So when I do this Eaton flap, so to speak, it is now extraordinarily wide. It's probably half the width of the fascia of the flexor peroneal mass. And so it's much wider than I think I used when I started. And I agree with you, it can become a problem, especially if you're not cognizant of where your skin incision lies. So do you suture that flap anterior to the anterior skin flap, to the posterior skin flap? But with the fasciocutaneous, you have this great fat that essentially you're laying right on the nerve. And again, you want to be careful not to constrict the nerve, but you're laying it right on the nerve, and what better tissue on which to, have a nerve resting.
Yeah, exactly. And that came up in discussion this week when I was working with one of our residents, Liz Grasser, who I'm slowly but surely assuring her that she will be a hand surgeon. But and she's wonderful. And it's more about learning different techniques, because you never know when you're in a revision, you'll have to pull out different types of techniques to use, because sometimes your go-to procedure isn't going to be available, which is what happened to us recently in a revision. So thanks for the nerve talk. Let's talk about other injuries that occur in the sports population, baseball in particular.
Right. So I think the first, if we're talking about hitters, and maybe we'll just make this about hitters, there's a few injuries which I think we should discuss. But the first is just a basic discussion, which I don't think anyone ever explained to me. Not that I'm some rocket scientist for figuring it out. I wasn't a baseball player, but if listeners are not baseball people, hopefully this setting the stage helps. So if you're a right-handed batter, what that means is your left hand is below your right hand on the bat, and you're standing at the plate. And when you swing, it's really all about your left hand. Your right hand's on the bat to stabilize it. But when you swing and then when you follow through, you end up ulnar deviating the wrist at the final follow through. It's all left hand or non-dominant hand, depending on factors. But a right-handed batter is at risk for left wrist issues. And I think we can briefly discuss three somewhat common issues. One is hook of the hamate fracture. Two is Tfcc, and we don't need to go into detail. And three is the ECU tendon. Those are the three that immediately jump to my mind. I don't know if you have general comments before we dive in.
I mean, it's the first thing that came to mind with that kind of follow through and the ulnar deviation, obviously, is the ECU. Does the first compartment ever get irritated, the first dorsal compartment, with that repetitive ulnar deviation moment?
No, it seems to be resistant. I haven't experienced that. I'm trying to think if I've ever even seen radial sided issues. Of course, I'm sure I have, but radial sided issues are uncommon in general.
So let's talk about that hook of the hamate fracture. Is that with specific types of impact, or is it a repetitive kind of stress to the bone?
To me, it's a repetitive stress to the bone. There is evidence, and it's actually pretty good, that the handle of the bat, the knob of the bat, which is the very bottom of the bat, impacts this. And there are bats that have a different shaped knob that seem to decrease the risk of this repetitive stress on the hook of the hamate. And if you see a hitter who's been in the cage a lot, they'll have calluses right over the hook of the hamate. And so you're getting repetitive force. And I do believe this is a repetitive issue. And then at some point, you get the fracture of the hook of the hamate. And when that happens, you can't swing anymore. So I don't think it's usually everything's fine, and then you break. Instead, I think it's micro trauma, and then ultimately the fracture. And we know that it's at this area of poor blood supply where the hook meets the body of the hamate. Ultimately, it breaks. And I think it's become more clear to be direct in our approach to treatment.
So what's the calculation there? Do you just excise it, pluck it out, and you're done? Can they get back to batting after that, or do you have to fix that thing?
So surgical repair of the hook of the hamates, in my mind, is a no-go. It doesn't make any sense for a couple of reasons. One, you're trying to get a poorly vascularized area and small area of bone to heal. Two, it doesn't seem like anyone ever misses the hook of the hamate, even with high-level performers such as baseball players. And so you can cast somebody if you want, and again, hold your breath and hope, but to me, that doesn't make sense. Even if it's a non-traditional hook of the hamate fracture, meaning an acute trauma in a non-baseball player, I just don't think it has much of a role. And so for me, it is hook of the hamate excision is a very satisfying surgery.
So is it that you mentioned after they have this kind of repetitive stress injury to the hook of the hamate that they can't bat anymore? Is it because of the pain from the fracture that they can't bat? So, excising the hook of the hamate once they get over the surgical pain, is there any role of mechanical support against the hook of the hamate in terms of the bat?
No, I think once you treat it and take it out, you're done. And it's just a matter of when they can get back to batting. And so, we shared our experience, Doug Carlin and I. Doug was a fellow here way back, maybe 20 years ago. and he has helped take care of the Rays for many years. And then there's been a couple other papers recently, a paper out of Phoenix with a large series as well. The message is the same. People, players do well with hook of the hamate excision. The question is risk of complications and return in timing of return to play. I think in experienced hands, the risk is low, but sometimes the nerve gets irritable after surgery. I would say that's the biggest risk. And the second issue is return to play. And so I tell people to expect 6 to 8 weeks, but it is highly variable. I think some players are back batting at 2 to 3 weeks and playing full bore by 4 weeks, and rarely get someone who takes longer. So that's the part that's hard to predict, but it's based on pain and tolerance.
Assuming everything goes the way you expect it to in surgery and the wound heals, when will you allow them to start batting to test things out?
Yeah, usually at 3 weeks, I'll say if you want to take a lightweight bat and do some light hitting off a tee, I'm fine with it. Or even, swinging a wiffle ball bat or something like that, and then go to, progress from there. But some people look at me like there's no way that's happening at 2 to 3 weeks. And other people will say at their first post-op visit, hey, I've been taking some swings and doing fine.
Is it the weight of the bat or the velocity of the effort?
I think it's a combination. That's why the lighter swings and the lighter bat help. And then
So
I'm sorry.
I got to ask you, you mentioned nerve before I did. Do you routinely decompress zone 2 of Guillaume's canal as you do this, or do you just make sure you visualize the nerve?
So, that is obviously the risk. I believe in fully exposing the nerve, careful retraction, and that means a little bit wider decompression so that you don't retract it at one little point, and not over retracting, which is going to cause, potentially some tingling in the finger thereafter. And obviously that's the risk of the surgery. And so, yes, I expose, I protect, and that's the only thing. You think it's a really small little piece of bone, and you make a small incision, you take it out. Not really my approach. Still a palm only incision. I don't like to cross the wrist crease because I think that wrist crease crossing incision gets irritable. But find the nerve, expose the nerve, gently retract the nerve, take out the hook.
If anybody out there repairs these and has had a good experience repairing hook of the hamate fractures, let us know. Chuck is saying that the literature would point to otherwise, but if that's your experience, please let us know.
Absolutely. And I'll say one thing before we switch topics. Don't get fooled by thinking the hook of the hamate is always the only issue. So 2 comments there. One, the physical exam is pretty classic, right? You feel the piezoform, you go about a centimeter and a half distal and radial, and you put your finger on the hook. And most people are most painful there. And if there's no other pain, great. The other test you can do is resisted little finger flexion. And, you can think about the flexor tendons wrapping around the hook. That will be painful and often positive. But sometimes it's just a little vague. And some people will have pain dorsally or ulnarly over the hamate bone itself. And some people a little proximally at the fovea. So the warning is don't be too quick to say this is absolutely a hook of the hamate and nothing else is going on. Try to make sure nothing else is going on.
Are there cases in which you're getting advanced imaging like an MRI and looking for edema pattern or anything like that in the hook? And if you see that, are you going to stop them and immobilize them and slow them down before, obviously you're not going to take out a hook that's not broken, or will you?
Yeah, so carpal tunnel view is the x-ray of choice. No other x-ray has the potential to show this. If the x-ray is not confirmatory despite a strong clinical suspicion, then either MRI or CT can be helpful. If it's broken, you deal with it, even if it's non-displaced in my mind. The question, of course, is when it is not broken and you do try to rest, you try to let them rest. And I don't like to take out non-broken hooks, but edema is highly concerning, and you have to get that to resolve, or else you're going to be back talking to this player in another 3 months.
I can just see you in there with your osteotome chipping out that hook of the hamate, tickling the recurrent motor branch, or the deep motor branch. So don't do that.
Definitely not. Definitely not.
So you mentioned TFCC as the next kind of group of issues, next in a group of issues for batters. How is the pathology different there compared to any other TFCC injury?
I don't think so. And there's not a pattern that I've seen over and over. Meaning there's not for example, it's not always central tears or volar or dorsal tears or foveal tears. It can be pretty much anything. And often it's an inflammatory issue, right? A lot of synovitis develops, and there may not be a prominent tear, but I start with a DREJ examination to make sure the DREJ is stable, check for foveal discomfort. And these are patients that if I really think it is there's a stable DREJ and focal discomfort, I don't mind doing a steroid injection as a one-time intervention for both diagnostic and therapeutic purposes and see what happens. And I've been happy with that. Sometimes, you treat it and patients don't come back.
And are you typically, what's your threshold for, say you've done, therapy, different types of supports, braces, orthosis, and you've tried an injection? What's your threshold to go to surgery?
Again, it's all about the athlete and the family. If it's a younger patient and their patience. And I'm not one who preaches patience beyond reason. We need to be, I feel like we as physicians need to understand priorities. And so if I have immobilized for 6 weeks, which I'll do with an acute event, concern for TFCC, if I have done anti-inflammatories and some therapy to try to calm things down, if I have done a steroid injection with temporary improvement but recurrence, I'm offering arthroscopic assessment at that point in debridement.
So you mentioned immobilization. Is that the true old school above elbow kind of Munster situation? Or are you more kind and perhaps allowing a little motion at that TFCC and staying below the elbow?
If someone walks in the office that has what I believe is an acute TFCC tear, focal pain, perhaps a suggestion of instability, or an MRI that shows the finding, I will put an above elbow cast in neutral rotation. However, that doesn't happen. It just doesn't happen. You don't see patients acutely almost ever, but if they do, then that's what I push for sure.
How long do you have them wear that for? 4 weeks, 6 weeks?
6 weeks, Munster.
How much do they hate you at 6 weeks?
They like me because I'd take it off.
That's right. That's right. We've mentioned this in a past podcast. And then round us out with the ECU. I think this is something that is sometimes nebulous to diagnose. So tell us how you evaluate that patient.
I would say ECU instability happens for sure. And it's one of those things that some people would tell you, well, you can have an unstable ECU and it's not a problem. Well, it's a problem if the patient's coming in for it. If it's a problem that the snapping is painful. And so making that diagnosis usually is not that tough. But the classic is the patient will come in with the forearm in pronation, the wrist extended, and they're happy. And if you like the ice cream scoop maneuver, then that ECU will become unstable and will pop. Again, in an acute setting with an acute tear of the ECU subsheath, which does happen, repair makes sense. You could also argue that casting in a pronated extended position makes sense. That would be a Munster as well. But in a high-level athlete, it would be an acute repair. Most of the time, these are a little more chronic. Diagnosis isn't an issue. And in those patients, I'm a strong believer in transposing the ECU more dorsally, although a lot of what you'll read talks about reconstructing the sheath or deepening the groove. That just has never worked particularly well or made sense to me. And we've shared our results, which are pretty good. I'll keep babbling. Go
How
ahead.
do you think about this in batters? Is it different? Are ECU issues in batters different than general population, Joe Schmo, Jane Schmo ECUs?
I think it's just the forces they put on their wrist. And you can see the batters that make it look easy and smooth. And you can see batters who the forces that go across that wrist are incredible. And so I don't think it's any different. It's just kind of how they get there. And you either have in my mind, it's very simple. You have an unstable ECU tendon, or you have ECU irritability, ECU tendonitis, so to speak, which I think can be a little more difficult to diagnose and it can be a little more difficult to treat. But ultimately, it's immobilization, anti-inflammatories, plus minus one and one only steroid injection in that location for me.
Obviously, the risk with the steroid injection is rupture of the ECU, and that would not be good because obviously how powerful of a force that is, and the point that this patient in particular really needs ulnar deviation, as do many of us. But what are your pearls for injection if one were to try this?
So thankfully, knock on wood, I've never had a rupture. What you'll see in patients, and this is probably the worst area in the body, and you certainly have an opinion on this, but I think the subcutaneous fat atrophy in this location is riskiest for whatever reason. Certainly, you can see you can see it radially at the first compartment. You can see it over the ECRB origin for tennis elbow. But for me, this is the area that has little tolerance. That's one of the reasons a single injection is all I'll typically do. I inject about a centimeter proximal to the DREJ. I don't want any diagnostic confusion. So if I'm giving an ECU injection, I want to know that it worked at least temporarily. It helps me confirm that this is ECU problems and not something else. And I typically, obviously, don't want to inject into the tendon. I inject adjacent to the tendon and use the ulna, the dorsal ulna, as kind of a landmark.
When you're inserting your needle, how do you know that you're at the right depth? Are you feeling tendon, walking, and then kind of pulling back, or are you kind of adept enough now with knowing kind of layers you're working through before you get to the tendon?
Well, I'm not an ultrasound guy, but certainly this is an area where ultrasound could be helpful. I think thankfully it's not very hard to palpate typically. So you can palpate the ECU, and I usually use the bone as my landmark. I'm not going down trying to stab the bone because I think that's cruel, but aiming for the tendon, usually going just beneath it and injecting there. How do you do it?
Pretty similarly, I've only had to inject a few, and I think at this point, honestly, I would use ultrasound. Either I would do it myself with ultrasound if I felt confident with that, or if the anatomy was a little more challenging, I would send it to one of our partners for ultrasound. It's super convenient to have the ultrasound in the clinic, but also to have our physiatry partners who are so good with the ultrasound too. I've learned so much just watching them scan too.
Yeah, I have no doubt. So, I think baseball is a fun sport to be involved with. Certainly hand surgeons have a role. Some of it's really silly, when a pitcher gets a blister, that's a major problem. But there's all kind of hand and wrist and forearm issues in baseball, which I think can be very fun. And certainly we can dive deeper in some other areas. And like I said, maybe have a guest on to talk UCL at some point.
I think that'd be great. Now, remember the thing that we're doing this season is that we're closing with one win. So do you want to share a win that you have, or should I go first?
I have one, but you go first.
We got to see the brachial plexus in all of its glory this morning, and that to me is a huge win. Honestly, the opportunity to have the cadaveric specimens to do that, it is honestly one of the things I love the most during the academic years, getting to do this lab and hearing our trainees. Maybe they were just saying it for me, but they really appreciated it, and I know they did. So that was a big win for me.
And that is why it is a beautiful thing that we are partners, because looking at that brachial plexus just brings flashbacks. My win is the receding nature of Omicron and the fact that optimism is here. And as the weather warms up, I think those two factors together, especially if we don't get hit with another wave of something, really feels good. There's just so much going on right now and so many challenges that this feels like a really big directionality change. I went to, my wife is an entrepreneur, and we went to a dinner to support budding entrepreneurs, and we had our masks on, and we knocked on the door. Relatively small group, and walked in. There was not a single mask to be seen, and I a moment of panic, and then we took off our masks, and a few days later we're fine.
That's okay. I'll see you. Maybe I won't see you at work this week, but okay. I think what's one thing that's interesting about Omicron and COVID in general is that you really see people's individual appetites for risk. And I don't say that in a negative way. I just say that in a very kind of factual way. Like, everybody's got their own calculus of who they're willing to hang out with and in which capacity. And it's very interesting. So yes.
It's very interesting, and you factor in mental health. I mean, this is really an interesting time. It's good to live in interesting times, Chris.
Absolutely. Well, you have a wonderful week. I'll see you next time.
Thank you.